Our second case study, 2 tries and you're out admission, is a real-life experience of a patient on Medicare who regularly sees a primary care provider and who is not a healthcare professional. She is now seeing an orthopedist for left shoulder pain. The orthopedist had referred her to physical therapy. The patient had 6 months of physical therapy, but with increasing pain and reduced range of motion, so her orthopedist suggested shoulder joint replacement. The patient was scheduled for surgery, has lab work done a few days prior. The orthopedist finds a urinary tract infection, or UTI, which was asymptomatic, and prescribed antibiotics, which were taken, and the surgery was rescheduled for 1 month later. At that time, 1 month later, the patient has complete lab work done again the morning prior to the rescheduled surgery. At 3 p.m. that day, the patient has not heard if cleared for surgery the next morning, so calls the orthopedist office. A nurse, not clear whether this is RN or whatever, informs the patient that lab results have been received. The patient asks if surgery is still on for the next day. The nurse checks the surgery schedule and says yes. So the patient calls her son at 4 p.m., who will get in his car right after work and drive from 5 hours away to be present during the surgery the next morning. The next morning, the patient and son arrive for the surgery. The patient is prepped, placed on a gurney, and rolled into the surgery suite, with the orthopedist in hot pursuit, saying that the patient still has a urinary tract infection, still asymptomatic, and can't have the surgery. The orthopedist renews the antibiotic prescription and reschedules the surgery, again for another month later. The patient the next day calls the orthopedist's office to inquire why she was told the surgery was on when clearly lab work indicated otherwise. The nurse she speaks to, again not clear exactly who this is, states that nurses are not permitted to read lab results. When asked when the orthopedist reviewed the results, the nurse reported that there was a readback at 3:18 p.m. When asked why no one called, the nurse stated that the orthopedist should have called. The patient decides to seek another orthopedist who can do the surgery and requests original orthopedist to send medical records to the new orthopedist. The new orthopedist does not get the patient's medical records and requires another full workup and also wants additional physical therapy prior to considering joint replacement surgery. The patient states she has level 7 pain that is unmanageable and keeps her from doing many activities, including having concern about driving and especially the ability to open the driver's side car door. She is now uncertain what to do. So some questions that we might ask for this case study include, what form of workflow and process tool would best illustrate the workflow here? What are the key issues and possible solutions in this process and its workflow? Who should take the lead in recommending a workflow and process improvement in this case? What is the impact of value-based care, and who will be at most risk? Again, take a moment to reflect and jot down your answers or pause the recording. Let's look at some potential answers for case study 2. What form of workflow and process improvement tool would best illustrate the workflow here? Most likely a systems flowchart, although a flow process chart to annotate time might also be effective. But really, I think in this case, the sequence of steps are pretty specific and is probably not essential for any one particular tool to be used. Second, what are the key issues impossible in this process and its workflow? Well, first of all, the PCP probably should have been involved to address the urinary tract infection, potentially referring the patient to a urologist. Reporting the urinary tract infection to the patient was obviously an issue. The patient may not have known to call the lab, which is allowed under nuclear regulations to release results to the patient. Results could also have been automatically posted to a patient's personal health record, although in this case the patient did not have a personal health record. But many organizations are developing and linking their EHRs to personal health records. The nurse should be allowed to read the results to patients in a process similar to reading to physicians. And who the nurse or physician should be calling the patient to reschedule needs obviously to be clarified. My best bet would be on the nurse, because the physician by the end of the day is really too busy with many, many different types of follow-up calls. Who pays for the surgical prep? Notice I don't have an answer to this because it's not really clear. And since it is Medicare, it probably is going to go straight through Medicare, but then that really means that the taxpayers are paying. And ultimately, in a value-based care environment, this would put the hospital at risk. Failure to send medical records to the new orthopedist is another issue, and it certainly appears to be intentional information blocking, or at best sloppy practices. This could certainly be an issue of competition. Variation in protocols for shoulder joint replacement. In other words, one who wants to do the surgery after 6 months of physical therapy, the other wanting a more thorough, different perhaps workup and more physical therapy, could be a result of lack of trust or, again, interest in getting a fair share of reimbursement for this patient. Who should take the lead in recommending a workflow and process improvement in this situation? A primary care provider is considered a general contractor in value-based care and should theoretically take the lead. But it is unknown if all physicians involved in this case study are part of the same Medicare ACO. And so really, part of the problem we're having with workflow interoperability across entities is that the entities have no need to work together, and there is no general contractor, if you will, across disparate entities. What is the impact of value-based care and who will be at most risk? If both orthopedists have bundled payment contracts, they could both be at risk. If all physicians are part of the same ACO, depending on what type of ACO they signed up for, the primary care provider could be at most risk. Although at this point in our transition to value-based care, full risk is not being adopted by very many by contract.